Greetings, Uday. Are you there? Hello, testing, 1, 2.
Hello, Dr. John. How are you?
Okay, you can hear me.
Yeah.
How are you today?
Yeah, it's okay. How are you, sir?
Very good. It's early here. It's, well, early, not for a surgeon, 6:40 in the morning.
Good morning.
Yeah. And there
It's,
it's what, 3 in the afternoon, 5 in the
Yeah,
afternoon,
it's
right?
around 3. It's around, yes, 4 p.m. in the evening.
Okay,
How's the weather there?
beautiful. Well, actually, no, it's not beautiful. It's just changed. It's probably like India. It's very seasonal in Miami Beach. It changed from being beautiful, sunny into now rainy season. Not intensely rainy, I don't think, like India, but mildly rainy.
India has a range of weathers. We have all the 4 weathers because it's along the equator also passes through it. There's a difference. So you can have winters also, summers also, autumn also, spring also. You have a variation of weathers here.
Okay, yeah, and monsoons. Do you have monsoons?
It's around the corner. I think by the end of next month we'll be having monsoons in North India.
No, that's
However,
intense.
around the
That's
coast of
intense rain, right?
intense rain, some, yeah. But at present it's very hot here in northern. It's very hot in the northern region. I think if you walk barefoot on your feet will all get burned. It's around more than 40 degrees, 45 degrees in north.
Yeah, it's Yep, changeability.
Yeah, I'm saying it's very hot in the here in the summer. Actually, we are having summers in North India.
Oh, summers, yeah.
Yeah.
It's very hot
However,
then.
so that's around 45 degrees centigrade, 45 to 50 hours. It's sometimes some places have touched 48 here also.
You know, I can't think in centigrade. I don't think in centigrade. When I hear 48, puzzled.
Yeah, I mean we have, yeah, it's
Because you know we have Fahrenheit, right?
exactly. So it will be around
You got a
I
calculator there?
yeah. So that's around 111, 13 degrees, 113 Fahrenheit.
Oh, wow. Over 100?
Yeah, over 100, definitely.
Oh, wow. Because you don't hear that word much around here, over 100. It doesn't
Yeah,
go,
so
it
it's
doesn't
different.
happen.
In south, it's and around the coastal regions, it's different. North has a heat wave at present. It so because that's why India has all kind of weathers or the range from north to south. There's a all range of weathers here.
Excuse me
And if
just for a
COVID has abated there or is
Yes,
it
it has. It almost looked like it didn't exist, except some
good?
people, hysterical people are wearing masks,
Exactly. Yeah,
running around,
that is hysteria
when
only.
it's not happening here.
That is hysteria. But
But how about
here
you?
also
How
it's
about
very
you?
less.
Are you guys doing okay where you're at?
Sir?
Are you doing well where you're at?
Yeah, yeah, I'm good. Thank you, sir. Thank you. Thank you. You're planning to come someday here in India?
I've been to Nepal. I went to Nepal.
Yeah, yeah. You told me that you had went to the conference with Dr.
Yeah, actually, I spent 3 months there. It was more than a conference. I was getting to know people, etc. But
How's the weather there? I mean, it's coastal region, I think Miami, so it must be a bit humid also, or
yeah,
is it?
it's just it'll get humid. Yeah, it'll get humid in the next couple of months. And
Okay.
that's what makes the heat kind of unbearable, is because of the humidity. Like right now, if it's when the sun comes out, it's not humid, but in a couple of months, it'll be very humid.
Yeah.
August, September.
It's a very tight schedule for you, I think, with waking up at 6 o'clock and starting the broadcast.
No, it's not. No, it's like, well, medicine.
Yes,
When
sir.
you gotta show up at
Yes,
some
yes,
conferences, you're busy at something, but you gotta go. So that's just how it is.
yes, sir.
And doctors understand when you say you work hard. They understand it
We are
because they do.
trained.
Because they do too. They know what the hard life's like.
Exactly, sir.
So it's like, yeah, we just understand it. We have a basic understanding. That's just the way it is. You have a problem at night, you get up and take
Mhm.
care of the problem.
Yes, sir.
Simple as that. Because people will ask, well, your time, it does kind of screw your time schedules up. Now that I'm getting older, and it's the
Yeah,
time
at times I
seems
think at
harder.
times
Yeah.
the hours you have some odd hours also. I've been like listening.
If you let it, it can drive you crazy. The
Yes,
time, because some zones change and you don't know it, and all of a sudden, whoa, they'll
yes, sir.
change in hours. So you got to kind of try to keep on top of it. Good morning, Zinab.
Hi, John.
Okay, Ashish, how are you?
I'm fine. How are you, John?
Go ahead.
Hello, sir.
Hi,
Hello, sir.
Zinab.
Hi. Hi,
Ashish,
John.
how you okay? Ashish, everything all right?
Yes, yes, I'm absolutely fine. How are you doing?
Okay. How about your camera? Can you turn your camera on, please?
Yes, yes, yes. I'll just do it.
Good morning, sir.
Hey, there's Zanab. She's Zanab. You're late. Usually you're the first.
I logged in and then my supervisor was asking me questions. I decided to log out and then come back again.
Oh. Okay, Zanab, I don't think Uday, this is Zanab. And there's Ashish. He's okay. Let me get off the let's see, put you on the screen here. Why isn't this okay, there you go. There you go. Do you know Uday? Ashish?
Yeah.
Yeah, you
Yes.
do know Uday?
Yes, Uday was with me. He had come to my center for around 2 weeks. He stayed with us.
Oh, okay.
Yes,
You may-
thank you,
you
sir.
may-
Thank you for the opportunity, sir.
You're welcome, Uday.
And there's Zanab. She's from Gambia, Africa. Oh, I got confused. Maybe not. Zanab, where are you from?
Yes, sir, you're right. You're perfectly right.
Can you repeat that, please?
Can you hear me, sir?
Yeah, the audio's not getting through there, Zanab.
Okay.
Audio appears to be bad.
Is it for me? Can you hear this clearly? No,
I
Zanab
can't.
doesn't have a good connection, so don't go by her voice. How does this voice sound okay?
No, it's breaking, John. It's breaking.
It's breaking. Well, I don't know if there's much I can do about that. That's Zoom,
Yeah.
or it could be your audio system. How about other people? Uday, am I breaking up my sound?
No. Yours is absolutely clear.
Yeah.
Uday was also absolutely
Ashish, it
clear.
could be your audio system. You want to work on that?
No, I can listen. I can hear you very well.
Okay, because I can hear you clearly now.
Yeah.
So I think we're okay.
I think Leo hasn't joined, right?
Not yet.
Okay. I'll just drop him a message. How much time do we have? We have about 10 minutes.
Yeah, we have 10 minutes. We don't have to start right on time.
Huh. Just got a message from Leo. He would be joining in 2 minutes.
Okay, great. Is everybody, we're still here. We're gonna start in a few minutes.
Yeah, I'm here, John, so already.
Okay, let me get back here. Okay, let me let Leo in.
Yeah, Leo has joined.
Yes.
Good morning.
Morning. Sorry to keep you waiting.
That's okay. No problem.
Hi, Leo.
How you doing, Ashish? Nice to see you.
Yeah, I'm absolutely fine. Good to see you.
Hey, just give me a minute, okay? Okay. Just give me a minute, okay, Ashish?
Yeah, please.
Ashish. Não tem nada, não vi tudo desligado.
Are we ready?
Yes, yeah. I'm just checking on a
So,
couple of panelists. Just a second.
So, John, I'm sorry. How do you want? You want Leo to go first, or
Well,
am I
whatever you want.
starting?
I'll introduce you. You're basically going to be running it. Okay, and then you go where you want to go.
Yeah, I
And then
think
you,
Ramesh must be here. He's the moderator.
okay, let's see here. Ramesh is here?
Yes, Ramesh is here. He's
Oh, hi,
moderating.
Ramesh. How you doing? Well, maybe I should just introduce Ramesh and he'll run the show.
Yes.
Okay. because, you know, for the questions after and manipulate. Hello, Ashish.
Hello, John. I'm Ramesh here.
Okay. Wait a minute. Who's Ramesh. Ramesh, I'll introduce, I'm John Bennett. I'll introduce you, right? Okay, and then you just run the show. Okay, Ramesh? Ramesh? Are you there? Ramesh, can you hear me okay?
You're right.
I think your audio is not working right. Ramesh, can you talk again, please? Well, there goes that idea, Ashish. So I'll just turn it over to you. Okay. Ramesh, we can't hear your audio. It's going to be hard to be a moderator if you don't have audio.
Ramesh, can you hear?
Yeah, now I can hear.
Okay,
Yeah, so,
can you talk? Go ahead, talk, Ramesh.
Yeah.
So I'll introduce you, and then you introduce
Speakers.
Ashish. Okay.
Yeah.
Okay, here we go. 10, 9, 8, 7, 6, 5. Hold on. Oh, I removed the pen. Hold on. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett for Neurosurgical TV. Today we have the minimally invasive spine brain forum. And I'm going to turn over the proceedings to Ramesh, who's going to run the show. Good day, Ramesh.
Yeah. Good day, John. Thank you very much for giving me this opportunity. I would like to introduce the speakers. So our first speaker will be Dr. Ashish Kendall. He was one of my colleagues who passed out from All India Institute of Medical Sciences, New Delhi, almost 20 years back. He will be speaking on radiofrequency lesioning for the trigeminal neuralgia. Our second colleague will be speaker for today, Dr. Leo from University of Toronto, Canada. He will be covering the role of MIS in the overall management of metastatic brain tumors. May I request Dr. Ashish to take up and share his views on trigeminal neuralgia, RF lesioning. Ashish, over to you.
Thank you so much, Ramesh. I'll just quickly share my. I'm sorry. I'll quickly share my screen here. Can you see my screen?
Yes. Perfect.
Yeah, we can see you.
Okay. So thank you so much, John, for accommodating this forum once again. And thank you, Ramesh, for the introduction. It is always a pleasure to be joining you for all these academic activities. Today, I would be speaking on radiofrequency ablation for trigeminal neuralgia. It's very close to my heart. I love this procedure. And I think many of us should take up this procedure because it's a game changer. Sort of, it gives excellent results and it is very quick and sort of with very, very limited complications. So we all know that for trigeminal neuralgia, the treatment options that we have include medical treatment, and in surgical treatment, we have the ablative surgery and non-ablative, which is the gold standard, the microvascular decompression. In one of these forums, we would also be taking up the keyhole approach for microvascular decompression. Now, as far as non-surgical ablative procedure is concerned, RF ablation stands above the rest. The last time we had a discussion on gamma knife when Professor Manjul Tripathi was speaking on the topic. We all know that trigeminal neuralgia is one of the worst pains that human beings go through. It is recurrent. We should be very sure of the diagnosis before we contemplate the type of surgery or the treatment that we want to envisage. There are triggers which we need to find out. We need to also pinpoint the exact territory, especially it is especially important when we are going for ablative procedures, and more so for radio frequency, because we need to distinguish between V1 and the rest of the neuralgias. We all know that females get involved more often. It's very less to find a patient less than 40 years with an idiopathic trigeminal neuralgia. The pain is restricted to the fifth nerve, and there are trigger points. Sleep is often not affected. So this is a very important clue that you can have as a clinician, and that is that one should always try to include this in the history taking. Also, the patient may go into remission. So once you have confirmed that, yes, this is a case of trigeminal neuralgia, then obviously you start thinking about the cause of the disease. We all know that, again, vascular compression stands on top of the list, where there could be a compression because of the superior cerebellar artery or primitive trigeminal artery or a dolichoectatic basilar artery. There could be other venous compression as well. Or there could be posterior fossa tumors, multiple sclerosis, and these are the various causes for trigeminal neuralgia. Now, once you have confirmed that whether you're looking for idiopathic or classical trigeminal neuralgia or secondary, then obviously you plan accordingly your treatment, and depending on the etiology, you would decide whether you are going for a surgical or a non-surgical ablative therapy. We all know that carbamazepine or oxcarbamazepine is the drug of choice. However, it is effective only in 60 to 65% of patients, and it has higher rate of side effects, especially in the long run. And many of the patients switch from medical therapy to the surgical or non-surgical invasive procedures for the treatment. As far as ablative procedures are concerned, we have glycerol rhizotomy, which is not that commonly used these days. We have balloon compression. It is very good when you have the V1 neuralgia. Percutaneous radiofrequency lesioning, which is the topic for the day, is the most common ablative procedure that is in use today. And we have already had a discussion on gamma knife. I'll quickly just share a few lines on balloon compression therapy. It is better for V1 neuralgia. The immediate relief is to the tune of 80%. However, the recurrence is 30 to 35% at 10 years. While you're doing balloon compression, the patient may suffer from bradycardia. There are reports that still the patient can suffer from corneal anesthesia and facial hypoesthesia. Radiosurgery, I would not be talking because Manjul, the last seminar, a large part of it was on gamma knife, and he went into real detail on gamma knife for trigeminal neuralgias. Now, as far as radiofrequency lesioning is concerned, these are my personal indications or my personal algorithm when a patient of idiopathic or a classical trigeminal neuralgia would come to me. So failure of medical treatment, obviously, then I start thinking of the ablative procedure. Patient preference. Now, even if the patient is a patient of 50 years, male or female, with no comorbid illness, and who is not willing for a microvascular decompression, I would still go ahead and offer radiofrequency lesioning to him. So if the patient's preference is for radiofrequency lesioning, I would respect his decision and go ahead and offer him the therapy. Sorry. Again, in aged or when there are medical comorbidities, or if there is a recurrence after microvascular decompression, the preference is when there is V2, V3 neuralgia. As I have already mentioned during this lecture, that it is the most common percutaneous procedure that we undertake, especially in the elderly. Mostly it is fluoroscopic guidance. There are other ways like CT guidance as well. The immediate relief rate, though it is not, it's mentioned here 97, but I would keep it at between 90 to 95%. And the recurrence rate is to the tune of 15 to 20% the first year. And obviously at 5 years and 10 years, it reaches up to 25 to 30%. So you can very easily remind your patient that the results would be a little less than what you can achieve through microvascular decompression, which definitely remains the gold standard. Okay, now as far as the technique is concerned, briefly, I use a 22 gauge 10 centimeter or a 15 centimeter RF needle or a cannula, which enters through the foramen of ovale. The tip reaches to the Gasserian ganglion. We do a test stimulation, and thereafter the lesioning is performed between 60 to 80 degrees centigrade for 60 seconds. We go ahead and give 1, 2, or at times even 3 shots. I'll explain the anatomy of the foramen ovale. Now, the foramen ovale is opening in the skull through which the third nerve, the third division of the trigeminal nerve comes out and supplies the mandibular and lower part of the maxillary region. Just above that, you have the Meckel's cave and the Gasserian ganglion sitting there. If you look at the internal part of the skull, here is the foramen ovale. It is lying just behind the dorsum sellae and at the level of the clivus, though a little lower down in the middle cranial fossa. If we flip the skull over and look from beneath, we find that the foramen ovale again is housed between the foramen lacerum for the ICA and the foramen of spinosum. So there are multiple foramen near to the foramen ovale, and one should be quite aware that you can injure different vessels if you are not respecting the correct trajectory. Looking to the contents of the foramen ovale, you have the mandibular division of the third nerve. You have the accessory meningeal artery, the lesser petrosal nerve, and the emissary veins. Just look behind, you have the foramen spinosum with the middle meningeal artery. Now, this is a very important photograph that I have brought in. In here is the foramen ovale, which is just behind the last molar. Behind that, posterior to that, you have the ICA, and then you have the internal jugular. So if you come in front, you can enter into the orbit. If you go behind, you can injure the internal carotid artery. So you should be very well aware of what exactly or where exactly you are perched. Now, once you are aware of the anatomy of the foramen ovale, we go on how to enter or how to cannulate foramen ovale. So for that, you need a good lateral view, lateral X-ray. In the lateral X-ray, you have to look at the anterior cranial base, you have to look at the sella and the clivus. And finally, you have to look at the petrous temporal. And this is the trajectory. This is the trajectory here. So to quickly give you a gist, the needle would go just at the posterior 1/3 of the hard palate, and it would be about 1 centimeter below the sellar floor towards the clivus. Here is a video, and it is a CT scan. This is the mandible which has been cut. This is the last molar, and here you can see the foramen of ovale. So this is the area you get to enter into the foramen ovale. Here is the other side, and this is the trajectory you need to enter to reach to the foramen ovale. Okay, I'll skip this. On the internal side, you are entering through the foramen ovale, and as you go higher up, you will have the mandibular, maxillary, and the first division of the third nerve as you go up. So the ophthalmic division would be the highest, and that is where you need to avoid. You need to avoid going there to prevent corneal hypoesthesia or anesthesia. Okay. Now, the technique of radiofrequency lesioning, this is the setup that you need. You need the RF generator. I'm sorry. You need the RF generator, which is a machine. You need fluoroscopy, and you would need a team which includes an anesthetist. On the technique of fenestration of the foramen ovale, the indications, apart from trigeminal neuralgia, the indications also include monitoring for epilepsy surgery, in especially temporal epilepsy surgery, and certain biopsies. But the main or the workhorse would be for the trigeminal neuralgia. It was Hartle 1914 who first introduced foramen ovale puncture as the percutaneous route to the Meckel's cave. And I have already elaborated the extracranial and intracranial anatomical relations of the foramen ovale. So it is a 7 by 4 millimeter opening in the middle cranial fossa anterior to the petrous temporal. So that is where you need to enter, and as your needle is entering, the clivus and the sella guides you to exactly where you need to end. So on sagittal plane, it has to be the mid pupillary line. So when you are introducing your needle, I'll just show you a video. The needle has to be in the mid pupillary line, approximately 1.5 centimeter lateral to the internal canthal ligament. That is where it ends. So again, another way to look at it, this is the needle. It is going just snugly besides the maxilla, medial to the mandible, and this is the opening, and you are entering into the foramen of ovale. So how do we decide the trajectory? So the entry is about 2 to 3 centimeter or 2.5 to 3 centimeter lateral to the lateral orbital fissure here. Sorry, the oral fissure, and from there you take the needle towards the mid-pupillary line. So you push in one of your fingers inside. The finger is touching your the inner part of the cheek mucosa, and you can feel the third molar, and then you are from externally the needle, you're guiding the needle towards the foramen ovale. This finger, which is inside, is there not only to guide but also to make you aware that you're not puncturing the mucosa. So traditionally we use fluoroscopy. We can use mostly I would go for lateral, but in case when there is difficult cannulation, I would go in for a submental view as well, wherein we tilt the C-arm. You can also go in for a 3D CT guided cannulation or a neuro navigation guided cannulation, but I can assure you that C-arm is what you really require. I've never used a CT based or a neuro navigation based cannulation. So again, I have elaborated on the trajectory: 3 centimeters lateral to angle of mouth, medially directed towards the mid-pupillary line or just medial to it. Okay, as far as electrode positioning is concerned or the needle positioning is concerned, you see this is the dorsum sellae here, this is the clival line, here is the clival line, and this is the Gasserian ganglion. So your needle or the electrode has to be within, say, 5 millimeter above or below this clival line. As you go higher up, you would hit the first or the second electrode. As you remain lower down, it will be second and the third division of the trigeminal. On to the complications. There can be complications if you are really out of the trajectory. Initially, you can injure the facial vein or the facial artery near the cheek, and you may have facial hematoma. This the facial artery and the vein is within 1.5 centimeter of the angle of mouth, and that is why you are 2.5 to 3 centimeter lateral from the angle of mouth to prevent hitting these two structures. You can create not only facial hematoma, but you can create a AV fistula as well. But this can be easily prevented if you measure from the angle of mouth and stay 2.5 to 3 centimeters lateral. The next complication that you can suffer is you can injure Stenson's duct, or you can alter the salivation. Again, if you are too low, if you are going low, then you may hit the duct. Otherwise, chances of injury is remote. Now, if you guide the needle too posterior, you may hit the carotid artery or the internal jugular vein. But for that, you have to really angle it posterior. If you enter through the inferior orbital fissure, so that means you're just taking the needle and going straight in. If you're going straight in, you can then cause injury to the orbital structures as well. But I can assure you, with an X-ray with you, you will not go there. As far as intracranial complications are concerned, reduced hearing, very rare. Alteration in lacrimation, nasal secretion with the GSPN can happen. Masseter weakness is perhaps the commonest, because when you're ablating second and third division, you can cause weakness of the masseter, and chewing can be affected. Now, to avoid intracranial complications, stay within 5 millimeters of the clival line. That is the dictum. Don't go too deep, don't go too much in, and you will be safe. So complication avoidance, early detection of the trajectory, look at where the hard palate is ending, where your sella is, and where your clival line is. Those three trajectory points will help you prevent any injury. Keep on using lateral fluoroscopy, and your needle should be placed correctly to avoid the complications. This was my past study. I'll skip this. Even this. Yeah, so this is one of my patient's x-rays. If you look here, the first thing that I look is the hard palate. So the needle has to be at the posterior 1/3 area of the hard palate. It has to be about 1 centimeter or so below the sella, and it needs to be within 5 millimeter of the clival line, 5 millimeter on this side or the opposite side. The important thing that you need to note is that the anterior cranial base, there should be no parallax. Okay, so now to some photographs and videos. Positioning, I keep a towel beneath the two shoulders. The patient is mildly extended. The anesthetist helps her with oxygen supplementation. There's C-arm, and we confirm. On C-arm, we see for anterior cranial base, we look at the palate, we look at the sella, and we look at the clivus. All these need to be seen for a proper cannulation of the foramen ovale. Lateral view of the skull, either you will get this position or there can be a mild extension. Thereafter, about 2.5 to 3 centimeters lateral. This is almost parallel to the lateral canthal line here. You mark it, infiltrate with local, the finger is inside. You start, this is this green top, and this insulated cannula is the needle. It has a 5 millimeter. If you observe very closely here, this last 5 millimeter is the active tip or the non-insulated tip. Here you can see the needle trajectory. My finger is inside, and the patient is obviously conscious at that point because you need to stimulate. Then here I have already cannulated. You can observe on a submental view the foramen ovale, which is very beautifully seen here. Once that is done, you do a test stimulation, that is 1 millisecond at a voltage of 0.3 to 0.5 volts. You stimulate. If the patient is telling you current, or when you see the motor movement, you are sure that you are in correct position. So here I'm trying to demonstrate the stimulation and giving the current. So here you can observe the needle. You can see CSF coming out. That is not a norm, but mostly you get clear CSF once you have cannulated the foramen ovale. And then this is the electrode. You pass the electrode for the ablation. Okay, this is the usual strength. I use between 70 to 75 degrees. The ablation is for 60 seconds. I generally use 2 shots, but you can go in for a single shot as well. Antibiotic for a day, gradual tapering of carbamazepine, and discharge after 4 to 6 hours. I've already discussed the complications. They are uncommon, rare, if you keep your needle well placed, and if you do not overburn or over ablate the nerve. The long-term results are excellent, though you should prepare your patient for a reprocedure or a recurrence. These are few important publications that I got. In one of the publications, the optimal RFT temperature to achieve long-lasting pain relief while minimizing facial numbness and painful dysesthesia may be about 75 degrees centigrade. So this was one important paper. The rest I have already covered. I'm extremely thankful for the patient hearing to all of you. I'll be more than happy to answer any of your questions. Thank you.
Thank you, Dr. Ashish, for an excellent and elaborative summary of your trigeminal lesioning for trigeminal neuralgia. In question box, chart box, I think there's only one valid question from Uday Gupta. I think you already answered that question regarding why we don't ablate the V1 branch. That is, it causes corneal hypoesthesia and may lead to corneal ulcers subsequently. Any other questions from anybody in the panel?
Ashish, I do have a question. I mean, it's funny because we're trained the same place and we went different directions. I like the balloon more because one, the patient is asleep, like fully asleep. I don't have to wake them up and try. And the other is, I found when I've seen it done by, I don't do much radio frequency, I'll acknowledge that. If I found a little bit unreliable the testing because the patient is half asleep and half awake and so on and so forth. I guess my problem here is that I don't have the same anesthesiologist all the time. And I think this is a function of the team you have. Is that correct?
Oh, yes. I think initially when you are stimulating, you need to be aware and you don't put the patient into deep sleep. But the other aspect that I've realized is that looking to the motor stimulation helps me a lot. Because ultimately I know the anatomical location of the V2 and V3, and if there is good motor location, motor stimulation, I'm pretty much sure that I'm very near to the V3 division. So less of anesthesia and for the stimulation, because it is just 1 millisecond. So it is very brief. And once I'm very sure, then obviously my anesthetist injects a little bit more of propofol for the patient to go into deep sleep.
Okay, thank you.
Okay, Ashish.
Ramesh, can I ask a question? I'm Ishwar from Sri Lanka.
Hey, please carry on, Ishwar.
Sir, good evening. Good evening, sir.
Good evening. Dr. Ashish, this is one of the excellent classes that we have had in recent times on this one. I'm sure I wish more reference had joined this to know about it, how it is done. You know, you spoke in a very halting manner, which could be comprehended by everyone. Thank you for this class. My question is, I use the flat panel CT. I've used the biplane cath lab for this because the cath lab is available with us. We use a flat panel CT scan to do a 3D CT scan. What comfort it offers is that when you have a 3D CT, it confirms whether your needle has gone through the foramen ovale, and two, it confirms that it is at the retroglycerin location. Both of which we have published our results in the Journal of Neurointerventional Surgery in 2016. So the problems that are attributed to the lesioning is often during the passage of the needle. So whether are you sure that you've gone through the foramen ovale or you've taken an aberrant trajectory. There have been instances when there has been visual loss after a failed attempt at lesioning. And there's been instances when it has caused a keratoconus fistula, etc. So to avoid such trouble, we use the 3D CT scan as a rule because it confirms two things. One is the passage is right. Two, the end location at the retroglycerin location is confirmed. It is not absolutely required, but it adds a layer of protection to the safety of the procedure.
Oh, yes, absolutely, sir. In fact, I'd gone through many publications, perhaps must have been one of yours as well. And there is no doubt that using CT scan or neuronavigation would definitely add, protection. Nothing to beat a CT, because that is the active and 3D way of confirming where the needle is. Obviously, fluoroscopy is 2D. That is number one. And the other problem with the fluoroscopy is that every time if you want to shift, from lateral to AP, it takes about another, 2 minutes or so, and then setting up the angle, the radiation, etc., etc. So if you can have CT scan, obviously nothing to beat that. I would agree with it, absolutely.
Good issue. Probably cath lab could be a good answer, because you have the freedom of moving taking the image in AP and lateral. I do use the cath lab for doing these cases. Ashish, one question, last question before we go to the next speaker, because both of these treatment procedures are really fascinating in terms of trigeminal neuralgia treatment. What percentage of your cases you use ablation, and what percentage of cases you use keyhole decompression?
Okay.
Ashish?
So I'll tell you my situation. So when I started keyhole about 15 years back in private practice, I used to operate maybe 1 or 2 MVDs in a quarter. So just about 5 to 8, I would have operated in a year. That remained the norm for 5-7 years. Then I obviously shifted to RF. And since the day I have shifted, I'm doing RF maybe 2 to 4 per month. It can be, or I'll say 1 to 4 per month. So the numbers have jumped. Now, to answer your question, I would be using less than 5 to 10% of cases as MVD, or maybe less. I now use MVD only when I have failed in treating the patient through an RF. Also, I think I have shifted towards explaining more the benefits of RF over MVD, because heart and heart I want to offer them RF as my first option. I don't know whether that is correct or wrong, but that is how my practice is.
Yeah, basically many literature suggests that failed MVD is an option for RF than the failed RF is an option for MVD, because in my practice, mostly like your type 2 trigeminal neuralgias or medically refractory cases are the key indications for RF, because most of the pain people who are not surgeons, they prefer to do these kind of RF first, go and then fail, then they refer to the surgeons. Why I ask this question is nothing. It's a personal choice on the patient reference also, because what are your percentage of patients who come back to you with paresthesias or dysesthesias, which is a part of RF ablation? So how disturbing is they're good initially because the pain has gone, but as the days passes on, they will be living with some kind of hypoesthesia or paresthesias. So what is your experience on the patient side?
Yes, I'll I'll answer all those questions. First of all, I would differ. I have had patients where in my own hands the RF has failed, and I have gone ahead and done an MVD, and the patient has had resolution of the pain. So so the reverse is also true. After a failed RF, MVDs are successful. That is my experience. I think Professor Easwar would also can elaborate on that. Second, your question about paresthesias and dysesthesias. Now, we all know that there is sort of an unwritten rule that if you have hypoesthesia, the patient would have pain relief. But in my cases, I find that initially 4 weeks, 6 weeks, 8 weeks, the hypoesthesia is more. And then gradually over 2 to 3 months, the hypoesthesia or dysesthesia resolves. But, and the patient has almost near normal sensation, but the pain relief continues.
Can I
Okay,
add to that? Ramesh?
Yeah, sure, please.
Where does RF stands in the treatment of trigeminal? Dr. Ashish has a valid point. You do an RF in a country like ours, where economic factors dictate the kind of treatment that patients seek. You know, microvascular decompression definitely is very expensive. RF is definitely an immediate outpatient daycare procedure. That is where RF stands. Another thing that I have noticed is in our country, a lot of people who are old in the older age group, that is 65 plus, suffer from RF. They are kind of morbidly afraid of open surgical intervention.
Yeah.
RF definitely has got a place for these patients. About the second question of the facial this thing, most of the patients welcome the facial numbness, as they call it, for some time, and they're getting used to it. In my series, we have our team has done close to 160 RFs in the last 4 years. We have not had any patients who had complained about this thing. We have had recurrences happening, but this facial dysesthesia and this hyperesthesia can happen in MVD also.
Yeah, but the chances are little less compared to the RF.
I used to work rarely.
Yeah. Anyhow, Ashish, it's really very satisfactory discussion and excellent presentation from you. Thank you once again. We will go to the next speaker. Dr. Leo, are you available?
Yes, I'm here.
Dr. Leo, over to you to share your views on minimal invasive approaches in the management of metastatic brain lesions. Thank you.
Okay, no problem. Yeah. I'll just share my screen here. Can you guys see the slide?
Yeah, perfect.
Yeah, we can see this.
Okay, so thank you very much for having me. This is my first time here. It's actually a great thing. It's quite informal and happy and nice. It's a good place. Thanks, Ashish, for inviting me. So I work at UFT. I'm actually a cerebrovascular and endovascular surgeon by training. I do some spine surgery. And my interest in MIS actually started with the idea that we have to find something to do less harm, so to move things faster through the healthcare system. I mean, you guys mentioned about costs and things, and even though Canada is in North America, we also have a universal healthcare system. So cost is certainly very, very important, and of course, to guarantee access to care for everybody. So doing things that are smaller, less aggressive, less invasive, it's important for any kind of operation that we do. It becomes especially important when you're treating something where you can't cure, right? So you're just part of a team. So Ashish showed some techniques and some technical aspects of it. I'm not going to talk much about that because what really fascinates me on this idea of this keyhole is the whole concept of how can you change from doing a big craniectomy, a big craniotomy, into being comfortable to working through a little hole and achieve the same result. And why would someone go through this trouble to do all that if you can just take out the bone and it's great, you can see everything from the lower nerve to the top nerve and it's fine. So why do that? And metastatic brain disease for me is the perfect example of that, right? So one, it's a very common tumor, unfortunately. We have improved the way we treat cancer. We can keep people alive for much longer, but we cannot keep them alive for long if they have a brain metastasis. And we can also not prevent metastasis from happening. So most likely we'll see more metastatic brain disease over time as people get treated and survive systemic cancer much longer. They will get more metastasis. The treatment it's not only surgical, it's also not only radiation, it's not only chemotherapy, it's a truly multidisciplinary thing. So you have to figure out a way to fit your operation into a team thinking, into a teamwork. So you're there as part of a team to help everybody and not just to, oh, I'm going to operate, take out the tumor, and that's it. And you have to keep the goal of the procedure in terms of treating brain metastasis very clear in your head. So you want to try to control and prevent progression of local tumors. So you're helping out with that particular aspect of that disease. So traditionally speaking, this is what we always hear about brain metastasis, right? So you remove the lesions you can access in patients who are doing well, and then don't have very advanced systemic disease. So if you put that into cancer treatment context, you help quite a few patients. There's not many that will be really, really well and needing that. And with gamma knife and other treatments, you may be required to do even less. You do stereotoxic radiation for lesions who are not accessible. You do it for multiple lesions. You do it for small lesions, and they're more and more involved in doing bigger lesions, staged gamma knife, allowing the gamma knife to treat larger tumors. So, but we all know that gamma knife also has some problems. So it doesn't deal with mass effect, may make it worse actually if the lesion is large. The treatment sometimes is delayed. The tumor may not shrink as you would expect to, and you can't have tissue for analysis. So in an age where we have molecular analysis and targeted treatments based on molecular biology, this becomes important, not only for the first diagnosis, but also to see tumor changing over time and help to guide treatment and clinical trials down the road. So when you do a standard operation, and this is how I used to do these things, so you do a large craniotomy because you want to see the brain around the lesion. You want to, even if it's a deep lesion, you want to see and be comfortable that you can turn around and look. You do a corticectomy that allows you to put a fixed blade retractor in there, which is something I haven't used for a few years. Knock on wood, will never use again. You do an extensive white matter dissection to get to the lesion for the most part, if it's the deep lesion. So all these things that you must do to take out the tumor will increase surgical trauma. So now you have a disease that you cannot cure, that you're trying to do something to help out the overall treatment, and you're causing harm. So, or you're increasing the risk of your procedure by adding those things. So this is, it doesn't become a good deal for the patient, in my opinion. So when we keep those things in mind, you start thinking that maybe you can do something a little bit less aggressive and obtain the same results, because what you really want is to control the disease. You know you can't cure that. You have to preserve function. This is very important. These patients have a short life expectancy. You want them to live with very good quality of life. You want them out of the hospital. There's no point surviving 5 years your cancer if half of that time was inside the hospital trying to recover from a hemiparesis. So you want to keep those things always in the forefront of your surgical decision making. And you can use many adjuvants. As I said, I'm not going to talk about a specific technique here. You do what you need to do to achieve maximal safe resection with minimal tissue damage. You can see here on the top picture, one of those transparent tubular retractors. You can use DTI to help you to plan your approach to deeper lesions. You must know that it's a little bit different to work through a little hole. You have to be trained to do that. You have to be comfortable with the fact that you can't see everything at the same time. You have to move things around, and you have to plan accordingly for that beforehand. And of course, you have to keep in mind that the idea that I was told that take the shortest approach to the tumor may not be necessarily applicable to every case. So safest may not be the shortest. So you have to always think outside the box. So this is from Dr. Theo's book. And again, this again is thanks to Ashish. So he invited me to go to India, and I had the pleasure of seeing him talk. And a very eloquent man, as you know, and he has these properties of keyhole. And what I thought was very interesting is that if you read the chapter, it doesn't look like you're reading a surgical book. You're just reading a newspaper or something, and he's getting through the idea very nicely. And these are basic principles that you should always keep in mind when you're planning your approach, especially if it's a small approach. So you won't be able to see everything keeping the microscope fixed. So we position the microscope and don't change it until the end doesn't work. The best view you have is in the middle of your keyhole, but you need to know that because you may have to turn around and see around that. So you have to plan accordingly, shave the bone off or change your craniotomy placement for that. You can't reach the surface under the bone. So the only surface you can reach is the one you can see right in the middle. And it's very hard to move these keyholes because you make a small skin incision. So once you put it in, you are kind of stuck in there. And the one that I like the most is that this is a concept. It's not a size. And this is from Pernesky. And it's an idea of how can I take out this lesion through the smallest possible approach, causing the minimum damage and still achieving the maximum benefit. So you're raising the bar to get it done as well as you can, as fast as you can, and really helping the patient. So I will just go over a few cases just to illustrate how practice shifted based on this particular approach. I must acknowledge that the people here at the cancer center are extremely aggressive. So you see patients that you probably wouldn't operate on, and we get involved. And as you do more, you get more involved because the patients do well and the outcomes are good. And of course, nobody wants to have a big tumor in the head. So it ends up that you end up helping a lot of people. So this gentleman is 72. He has renal cell cancer, and he presented to the emergency room with this headache. This was after gamma knife treatment. So all the other lesions that he has quite a few. They're completely stable, and this one had bled. So he sent over to us and, okay, could you take this out? We need to know what's going on, and we have to control this. Of course, they all think that the disease is very well controlled with the gamma knife and the other treatments, and the patient is in good condition. So you do consider that. You can see a problem here for these approaches if it's a large frontal sinus. So a traditional neurosurgical approach through the front with a bicoronal incision was thought to be too much, and we took out the tumor through this little craniotomy here that you can see on the left side. Note that he had another craniotomy in the past on the contralateral side, and you can achieve quite a good result. Patient goes home in a few days, if assuming there's no complication, and being followed and treated with radiation functionally really well. So another case that what these small openings allow you to do is to be a little bit more aggressive, because the idea that you're making a smaller opening, handling tissues more carefully, and it's much faster to open and to close. It gives you more flexibility. So this guy had melanoma and had two mets in the cerebellum who were also previously treated with radiation, and they were growing in spite of that. So good functional status, again, the same story. And then they come in and which one you're going to take out? They want both of them out. So the option would be traditionally to do two operations and bring him twice. So two anesthetics, two admissions. And we decided to basically just do one. And then the question came up, well, we'll do a huge midline incision, move all those muscles out of the way. Or maybe we can just do two small craniotomies, one on each side. It's a little bit annoying to position these patients sometimes, but it can be done. And you use navigation, and you can do these two little small keyhole approaches and take out these tumors. Another one, younger guy who came in and was thought to have metastasis, still unknown. So we did a small craniotomy, the temporal fossa, for a diagnosis. So there's minimum disruption of the temporalis muscle. You're not reflecting the temporalis muscle forward. There's not much atrophy, and you can remove that tumor well with, again, a very small craniotomy and allow him to move on. This turned out to be a glial tumor, actually, and but still, you can get it out to the same approach and provide a diagnosis and allow for other treatments and disease control. Here is another example of a patient who would be difficult to handle with traditional big operations. It's a very complex female with systemic disease. She has systemic sclerosis. She has lung fibrosis, pulmonary hypertension. She cannot be transfused because of antibodies. And she has this large metastatic lung cancer that oncology is struggling to control with radiation. So she's sent over, and after many discussions with anesthesia, we decide to do this small opening, which again, I said is like 15 minutes to get into the dura and another 15 minutes to close. And then it's just a matter of how long it takes you to take out the tumor. And she actually did relatively well. It took her a little bit of time to be extubated because of the pulmonary issues, but she was discharged in a few days with no significant complications. So this is a patient that we would just not do anything in the early past before that. And many of my colleagues today will probably not do anything because the traditional way to approach this is probably too aggressive for this patient. So another one with a large lesion, colorectal cancer, kidney failure on dialysis. So again, this is one of the unforeseen side effects of developing these techniques, is because you start getting all these cases that people find too complicated and patients are very sick. So they end up in your office because technically you can do, and it's not always the case. So you also have to have a good understanding of what's possible and what's not. You shouldn't think that you can just do everything because you can do it through a small hole. Some things are still quite complex. So once more, large lesion removed through a small hole. Very important to keep in mind the principles of these approaches, right? So you want the long axis of the lesion and so on and so forth. So all this has to be planned. And one last example here, which is an illustration that these techniques allow you to advance the scope of your practice. Allows you to do things that are usually not done, increase your reach in terms of oncology. Is this lady, 42-year-old lady with metastatic breast cancer. She presents to the emerge with trouble speaking and has this MRI. She actually has 3 lesions. There's another one smaller in the posterior fossa that was radiated after this. And we discussed this with the oncologist, and the thought that she would have to have a big craniotomy so you allow us to approach 2 lesions was immediately followed by the statement that, well, maybe she should just have radiation because radiation, it's not so traumatic. So because we're more familiar with this, what we decided to do is to use navigation and then do 2 small keyholes in the same approach. So we removed both lesions through the same, in the same setting, the same operation. Again, a little bit annoying to position. You have to strap the patient because you have to shift the bed to allow you to see through the best access to reach those lesions. But these were quite round, so that helped us a little bit. So you put all those principles together, you put all that concept together, and you see, how can I apply this to this particular patient, and how can I make this better, removing this lesion, and the patient, he will be out of here as if there's nothing happening, no big shaving, nothing, just walks out of the hospital. And he makes a massive difference. Not only, even if you don't make a huge difference in terms of cancer control, which you do, don't get me wrong, you do. The way the patient feels, it's amazing to see the effect that he has. And in this lady, we were actually able to get very good resection, took out both tumors. She was then treated with cavity radiation, and the other one was treated and she's doing quite well. So one final case to show you how you should probably start thinking outside the box. So June 2019, 65-year-old gentleman with prostate cancer. So showed up with this prostate cancer, technically well controlled, very high functioning gentleman. And he shows up with this cystic lesion. If people were not sure what was the problem, prostate usually doesn't go to the brain, and the lesion looked quite atypical. So it was growing, it was generating more and more symptoms, and then he comes in for an assessment to see if we could figure out a diagnosis for that cyst. So traditionally, we would do a frontal approach and coming inside the cyst and try to resect the nodule from inside. I thought this would probably be a little bit tricky because I would have to move, either retract the brain too much or put my craniotomy too far behind and go through a lot of cortex. So we actually decided to do something slightly different and did a similar approach to this. This is not the same patient, but this is just to illustrate the craniotomy. You do a small craniotomy in the supraorbital region, and through this small little hole, and with a small corticectomy, in this particular case, you elevate the frontal lobe slightly, and you can see that as you elevate the frontal lobe, you can go straight down to the nodule. And once we do that, in a short while, we had the tumor out. And this is his MRI follow-up last year. And you can see there's no recurrence, and the craniotomy is up here in the front, and he's actually doing quite well. So as I said, the fact that we're adopting this idea of taking out most of the tumors that we can through a small craniotomy, I now moved to everything I can, I do through a small opening, if it's possible. That's the first thing that crosses my mind. This allowed us to approach lesions that we would normally not do. We see very often cases are discussed at rounds, and the answer is, well, this is too dangerous. It cannot be operated on. But if you think about the case using a slightly different mindset, you figure out a way to do it. I'm not encouraging people to go do crazy things and do tumors that are absolutely not resectable, but I'm just saying that if you change the way you think, you may find that tumor is actually approachable. It's not that difficult. So a very brief talk and a brief conclusion. So the concept is actually very useful. It's more important than the technique itself. Like you have to have the whole concept in mind when you're approaching metastatic brain disease, which to me is probably the best use for this. I mean, it's very cool to take out a big anterior fossa meningioma with this little tiny opening. And we all had the pleasure of doing that. And it's really feels great. It's great for the patient. But when the concept fits best in terms of overall patient management, I think it's cancer, because you have the limited life expectancy, you have the quality of life issue, you have all the stuff that you need to consider. And again, it's more a philosophy than a technique. You need to really embrace it and then do well. So I leave the big wide open spaces to outdoors here in Canada, and I keep it small in the OR if I can. Thank you.
Thank you, Dr. Leo. It's an excellent presentation, and thanks for sharing a very good collection of cases which were managed with minimal invasive principles. The toughest of all the case scenarios, managing the metastasis is not that easy task through the minimal invasive corridors, but you have shown the excellent results. Any questions from participants, co-speakers, co-host? Okay, Dr. Leo, the minimal invasive principles which were popularized by Fernandes and a lot of other people across the globe, like Charlie Teo and other people, have really made tremendous contributions in the field of minimal invasive approaches to the brain and spine lesions. A small question, which with the advanced technologies like neuronavigation, endoscope, and advanced rail systems, globally, many people, especially the younger generation people, really adopted these minimal invasive principles. and it's almost now become a norm of modern neurosurgery than elaborating surgical principles, whether it is a conventional approach or minimal invasive approach. One question to you, greater section of these metastases, they arise from the posterior fossa. Posterior fossa lesions, do you operate under navigation guidance or not? If you're doing navigation guidance, do you select the supine with head tilt position or take the prone position to have a comfort for operating?
We use navigation. It's a bit of a struggle because sometimes it's not accurate. So what I like to do, because we train residents, so I want them to know of the navigation and use the navigation, but not rely on it 100%. So we use the prone position up front, and we calibrate the machines. Nowadays, you can get pretty accurate. It takes a bit of time, but you can get there. But I always mark it before using anatomical landmarks, and then I will check with the navigation and make sure that that's correct. So I see all those adjuncts as adjuncts. So they're there to help you. You should be able to do it without them. The endoscope may be a little bit of a different story because you needed to see around the corners. I haven't used it that much, but it's available.
Which navigation system you're using?
Currently, I think we have Stryker and there's a Medtronic. There's two.
Because Medtronic's
whatever it's available there, we use it.
Yeah, when we apply the frame in the prone position, the registration points like tip of the nose and the forehead becomes tedious, actually.
It becomes very, very time consuming sometimes. The new one, I think you can do a few points and just run on the back of the head and the occiput, and it's quite often it's accurate. But I don't think you should rely on it 100%. I've seen it can be quite off sometimes.
Yeah, I fully agree with you. It's like people's mindset. Many people think it's impossible to manage with the minimal invasive principles. As you experience and cross through the initial bottlenecks, it becomes a reality to manage nearly 90% of the brain and spinal lesions through minimal invasive principles nowadays. Any questions, Ashish? Because Ashish is the expert in minimal invasive principles working in India, central part of India. Ashish, please.
So, Leo, my question to you is, are you using any sort of dyes, fluorescence, or any other adjuncts for metastatic tumors? That is the first question. Second is that how do you approach metastatic tumors? Is it any different from a typical intraaxial primary tumor?
So we don't use any dyes. We use the navigation and it's not like a GBM or a glial tumor where you have to get something to color it for you so you can remove as much as you want. The second question on how do I approach them, they're usually a little bit more friendly to do, right? They're like round and they're easier to control using the MIS. So you put your craniotomy on a place where you're going to be able to reach both sides of the lesion and control it all around. The glial tumors are a little bit trickier sometimes because the shapes are different. And if you look at those craniotomies, they're all placed along the long axis. And the only reason why we're able to do those two tumors is because they're round and nice. If they're long, it will be even more difficult. That's probably the only concern in terms of placement of a craniotomy. You have to remember that if they're smaller and round, they could kind of turn around. So if you have a tube inside, it's a little bit difficult to grab them sometimes. The tube immobilizes you. And I still remember when I went to your place and I watched Dr. Theo and I asked him the question and say, do you use the tube? And say, no, I don't like it because it's to protect the brain from bad surgeons. So I said, okay, I think that's fine. I do find a tube used for hemorrhage, for example. We used it a few times. We're not using it now, but we used it a few times. So for metastasis, I usually just do regular corticectomies, no retractors, and I just really make sure that nobody's pulling on it. The residents have been trained, and it takes some time to get comfortable, that to know that you don't have to see the whole thing. You can just work here and work here and work here and work there. You just need to know what the path is, and it's working well.
Yeah,
Okay,
thank you,
I believe
Leo.
you-
There's a question to you. Sorry, somebody is asking.
Yes, Uday has one, I believe. Go ahead, Uday.
Okay.
want-
Leo, there's a question in the chat box from Dr. Uday Gupta from India. How do you manage post-op edema in malignant tumor surgery? So it's basically concerned about the edema post-operatively when you operate through a small keyhole. So how do you manage that?
So the same, right? That edema responds to steroids. So that's what you need to do. Of course, if the patient is herniating, then that's a different story. We're not talking about the same group of people. But you've seen a few pictures where you see a lot of edema surrounding the tumors, and it's surprising me because if you have a smaller opening, it's actually better. If you have a big opening, the brain comes out. If you have a smaller opening, the brain cannot come out. So it just contained in there. We give them a lot of steroids. And once you do your cortisectomy, we've had cases where you take some of the metastasis and then the rest is basically pushed out and it just comes out for you. And you know you're doing a good job when you finish your operation, your cavity is much smaller than the tumor itself. So you see that prostate cancer, for example, you see at the end, there's just a sleeve in the follow-up. So you're not resecting the brain. So the edema, it can make a little bit tricky to get down and move the brain around if there's a lot. But what we usually do is we give them steroids for a few days and then we do the operation after. They are not operated on immediately. So there's a bit of time.
Thank you, Leo. Any other questions? Okay, one last question to you, Leo. What is the percentage of recurrent malignant metastasis you operated through the keyhole approaches? And what is your kind of
Will
plan?
you do on the same spot?
No, I'm asking what percentage of your cases came with the recurrence, and have you had any opportunity to operate the recurrent same metastatic tumors?
Yeah, we're now noticing that they're coming back with. So what normally happens is that these patients go through the usual cancer treatment. So they will go to the cancer center. They have this multiple metastasis or one metastasis that it's not too large, and they would radiate them, and they're followed, and then it's growing. So it's one, or we've seen a few times where we got two or three, and two are very well behaved and they're shrinking and they're fine, and the other one is growing. So can you take that out? So we take that out, and usually it's tumor mixed with radiation necrosis, and then it goes well for another 6 months to a year or so, and the patients come back and it's growing a little bit. It's not too big, but the radiation oncologist cannot give more radiation, and they don't know if it is radiation necrosis or if it is a tumor. So I've done probably a handful of those. It's not many in all the cancer surgeries that we've done, but not that much. But they will come. I'm pretty sure they will come because it's just the nature of the disease. Right? The one side effect I must say is that the patient comes in, has a small cut here, goes home the next morning and tells his neighbor that he had brain surgery. And so next time he's sick again, it's very hard to convince them that the brain surgery is not the same, that they're gonna be in trouble. So they don't believe you. They want it done because it was so fine the last time. So the patient feels very different about it.
Thank you, Leo. I thank both the speakers for excellent talks and their experience sharing with us. If there are no questions, then I'll go back to John.
Okay, very good. I'd like to thank Ramesh, Leo Dante, and Ashish for putting this together. And I guess, Ashish, we have another webcast possibly in 2 weeks, maybe in a week, who knows?
Sure, sir.
We can do it, what they say in medicine, PRN, as we get speakers, good speakers like today, that we can do a webcast, and we'll keep in touch. I just want to show the community what's coming up here on Neurosurgical TV this week. Well, actually, tonight it is in Spanish. This is neuroanatomical webcasts and neuroanatomy of neurosurgery. And we had this, let's see here, we have one from Ukraine. Let's see, come down to here. Okay, we have management of military neurotrauma. That's on Monday, next Monday. And anyone's welcome to join the panel of the webcast. There's going to be four good presentations. And we can't be, as neurosurgeons, I mean, you have to treat those injuries, and you can't be shy. You know, high velocity agent TBI, penetrating head injury, management of combat TBI, management of combat peripheral nerve injuries. And these are all from neurosurgeons who have served from Yemen, served serves the wartime type of injuries. So 4 neurosurgeons who've had experience in that. So, okay, we'll end this webcast, and we hope to see you guys in the near future.
Thank you very much.
Thank you.
Good evening, I should say. Thank you. Take care.
Thank you.
Thank you, Ramesh.